the Indian Health Service Medical Support Center. Your representatives are Kristine, officer of the Indian Cancer Foundation. She does have a Bachelor of Applied Science from Minnesota Duluth Community Health Education in 1992, and an MPH from the University of Minnesota of Public Health from Minneapolis in Public Health Administration and Policy from 2000. Kristine Rhodes is an enrolled citizen of the Bad River Band of Lake Superior, Chippewa, and a Fond du Lac Reservation community member where she was born and raised. She earned a Master's of Public Health degree in Public Health Administration and Policy and a Bachelor's of Science degree in Community Health Education, both from the University of Minnesota. She has worked on improving the health of American Indian health communities for the past 2 decades. Her work has included the development and evaluation of many tribal and urban tobacco control efforts. From 2000 to 2010, she coordinated multiple research projects from the American Indian Community Tobacco Projects at the University of Minnesota. She is currently the Executive Director of the American Indian Cancer Foundation and American Indian directed nonprofit organization based in Minneapolis, Minnesota. Also, we have Abbie Begnaud. Is that correct, Abbie?
Begnaud.
Begnaud. The Assistant Professor of Medicine from the University of Minnesota. She earned her MD from Louisiana State University Health Sciences Center in Shreveport, Louisiana, in medicine in 2006, and a Bachelor of Science from University of Miami in Coral Gables, Florida, and biology in 2002.
Hello, everyone. My name is Josh Hudson, and I'm a program manager for the National Native Network. We're having some technical difficulties. If you're able to hear me right now, could you raise your hand using the raise your hand option through GoToWebinar? Okay, I'm seeing a lot of hands being raised. All right, we're going to switch screens. And we will continue from here. One moment. Did you want to do this? Because this isn't my thing, but I don't know what screen you want to show. Whichever screen.
Okay, sorry about that, everybody. Again, we were having some technical difficulties there, so we apologize for that. Just going to finish up the formalities. No commercial interest was used to support this webinar. Our accreditation, this activity is designated 1 contact hour for nurses, and to obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. Our learning objectives today are to examine the American Indian lung cancer burden, utilize current and updated guidelines to appropriately screen for lung cancer in American Indian and Alaska Native patients, and identify evidence-based resources and effective strategies to reduce the burden of lung cancer. At this time, we're going to go ahead and hand it over to Chris Rhodes in just one moment.
Hello, everybody. This is Chris Rhodes, and I am with the American Indian Cancer Foundation. I am so excited to be here today with you all for this webinar. Thank you for joining us. Our partners at the National Native Network, at the University of Minnesota, at the National Native American AIDS Prevention Center, and caring ambassadors are eager to share information with you. We have a handout that you can download on the side of the presentation. And we hope that you'll ask questions at the end and follow up with us as needed after the webinar. And so with that, I'll get started. I'm not able to advance the slides, Mike. Oh, wait, maybe. Okay, here we go. So with the webinar overview today is listed here, and I'm not going to spend a lot of time and let you know that there will be 4 of us presenting, and we will keep things moving. And I'm ready for next. So I want to start out to tell you about the American Indian Cancer Foundation. The American Indian Cancer Foundation is a national nonprofit that was established just about 6 years ago, and it's a Native-directed organization that is working to end the tremendous cancer inequities faced by American Indian and Alaska Natives across the country. And we do this through education, improved access to prevention, early detection, treatment, and survivor support. Our webinar today on lung cancer is definitely within our mission of promoting good education for Indian country, as well as options for early detection. Next. It's really important to look at, when we're looking to solve problems in American Indian communities, we really need to look to the expertise and the wisdom that exists within our communities. too often, American Indian, Alaska Native people have not been at the decision-making table. And I think that's a big result of where we ended up with the inequities today. We've found great success when we're able to engage American Indian communities from the very beginning, no matter what the topic is, and we're able to get to solutions on a more fast timeline. American Indian mortality data is limited. The first and best publication on American Indian mortality data was published in 2014 in the American Journal of Public Health. The image is featured here on the screen. And what we learned at that time is that in our communities across the United States, cancer has become the #1 cause of death for women and remains the #2 cause of death for American Indian men. This is really important and historic as again, this is the first time in history that cancer has become the leading cause of death for American Indian women, and we know that we can do something to change this story going forward. Next. Oh, maybe it is. I think maybe two of us are trying to control these slides, and I apologize. So when we look at the American Indian cancer data from that report, we see that cancer death rates for American Indians and Alaska Natives have increased over that 20-year span that was covered. And this is at a time where mainstream America has been really celebrating decreases in cancer mortality. Unfortunately, American Indian and Alaska Native communities are not celebrating decreases. We're still concerned about the increasing cancer death rates in our communities. And when we look, it's important to not just look at the national data. It's really, the data for American Indian and Alaska Native communities really changes by region. And we really have to look at the data not only by region, but within those large regions to look at within our local communities when we can for data that we can rely on. It's important to look and note that lung cancer is the leading cause of cancer mortality in all of these regions, except for the gray region, which is the Southwest, where it comes in as #2. And when we look at cancer incidence rates, we can see the most commonly diagnosed cancers. Lung cancer is the second most commonly diagnosed cancer for both American Indian men and women across the United States. But again, lung cancer is the leading cause of death, cancer death for American Indian men and women. And other leading causes of cancer death are prostate, colorectal, and breast. And this is important to note that this really ties in with when we look at some of the leading causes. Smoking of cigarettes and other commercial tobacco products, chewing tobacco, and cigarette smoke exposure of commercial tobacco products is the leading lung cancer risk factor, followed by radon exposure. Really important. These are things that are individuals. These are the individual behaviors and exposures that we see. But it's really important to look at what are the community and system level barriers experienced in American Indian communities, because the individual behaviors are really just a symptom of some of these other larger issues, such as the underfunded urban and tribal healthcare systems. We all know the problems that IHS faces when it comes to not having enough funding. We can talk about the lack of accurate population-specific data. We have high rates of poverty, poor access to health care, and low rates of health insurance. We also see a lack of culturally competent healthcare providers, or in a turnover of healthcare providers in a lot of our American Indian Alaska Native health facilities. There's also a limited availability of prevention programs, cancer screening, and specialist care, especially in rural areas. and unique historical traumas that we cannot deny anymore, that they have an impact on the behaviors such as smoking and then the resulting health outcomes that we see. Some of the significant challenges really tie back to some of the social determinants of health being poverty, trauma, the politics, racism, inequity. And we talk about these things sometimes as if they're in the past, but we have to recognize that these issues are here today and we need to deal with them because they are leading to significantly negative outcomes for our Native communities in terms of all kinds of inequity and poor outcomes, whether it's health, education, suffering, death, worsening equity. But I don't want to, we cannot stop in all the doom and gloom of all of the negative things in our community, because American Indian communities have resources that just are, the basis of our communities are about good health and well-being. We have our traditional teachings, and when we look at tobacco, we know that the traditional teachings behind tobacco really promote the use of tobacco as a spiritual medicine and reject the use of any recreational or addictive use of commercial tobacco. The voice of the community is another strength of our people. When our community is able to speak up and be engaged in sharing solutions, we really see positive outcomes. Tribal sovereignty is another example of what could be seen as a strength. Some people say it's a negative, but tribal sovereignty is a strength. And when we look at how our tribal leaders can make impact on the health of our communities by applying a health and all policies framework to all decision making, we've really seen positive changes within communities. And when we talk about tobacco, even as an example, we can look at what this looks like across a community. Tobacco control in American Indian communities looks really different. This is not what tobacco control looks like in communities in mainstream America. When we're talking about tobacco in our communities, at the center of that is about the access to traditional tobacco and education for community members on that use. We're also talking about enacting tribal policies that improve and protect the health of our people, that limit the exposure to secondhand smoke, that limit access to purchase for youth, and promote traditional cultural and American Indian cultural values around tobacco and solutions. This is an example of how we can make a difference in our communities. Tobacco in Indian country is, again, really different than what we're talking about in other communities, and we're going to spend a few minutes here just talking about what that looks like. First of all, we have to recognize that tobacco addiction is alive and well in our communities, and what that has resulted in is a public health crisis for American Indian people. Rates of current smoking among American Indians in Minnesota has been documented at 59% in a study that we did back in 2012. That exceeds the highest ever U.S. smoking rates of 42% back in 1965. Smoking is linked to almost all health indicators and closely tied to leading causes of morbidity and mortality. Like I've been stressing throughout this webinar so far, is that we have to keep this in context. We have to recognize that the smoking is happening as a result of the trauma that people experience, both historical and current, the stresses faced by American Indian Alaska Native people, and the historical repression of culture and attempts at extermination. Our people are using tobacco in ways that have turned into self-medicating and addiction, and yet there is so much efforts to reclaim that traditional tobacco use as a medicine and spiritual healing power. We're seeing this happening, and it is powerful, it is strong, it is happening across the Northern Plains, where people are using tobacco as it is intended and really rejecting the use of commercial tobacco. And what does this mean about using tobacco as it is intended? For American Indian people, that means we have traditional uses of tobacco that are spiritual, where tobacco is used in ceremony and prayer and in out of signs of respect. We have medicinal uses that tobacco uses to keep us healthy and strong, and even for healing purposes. We want to recognize that traditional tobacco use does not include the use of tobacco in cigarettes. It is not always burned when it's being used. A lot of times it's being used as an offering without being burned. And even when it's burned in a pipe, it's important that that smoke of the tobacco is not inhaled, that that smoke is intended for the Creator. So that rises to allow your prayers to go to the Creator. We also want to recognize that there are different types of tobacco, and the commercial tobacco, when we talk about that, that's the tobacco you buy in the store, and it's loose cigarettes, it's loose tobacco and cigarettes. And then we want to recognize that traditional tobacco is usually not bought in a store. It is usually gathered or grown in our communities and is local to the community. When we ask why are American Indian tobacco issues so complex, we have to recognize that the lack of religious freedom didn't happen until 1978. Until that time, people had, if they wanted to practice traditional tobacco use, they had to use the commercial tobacco as a way to hide in plain sight. There are cultural norms in communities where commercial tobacco is still used in cultural practices and ceremonies, and there are efforts to change that. We've talked about the historical trauma, and we could spend a whole webinar talking about both historical and current trauma and the impact of that on American Indian people. And that, of course, includes the boarding schools and loss of culture. Out of interest of time, I'm going to keep moving along. The tribal and economic issues are a factor that sometimes makes addressing tobacco addiction in our communities difficult. But we continue to do this work. There's also the cultural identity and imagery on tobacco products, where American Indian people's images are used, and it becomes an issue that American Indian people, youth especially, see that this is something that American Indian people should use. And just the fact that smoking, when more people smoke in our community than don't, it's really hard for people to not start and to quit smoking when folks around them are smoking. So we really need to remember that it's not just as simple of getting people to just quit. Just quit is not quite the answer. I want to point out that I wanted to do a takeaway on American Indian tobacco and leave you with a few points, is that all of our efforts should really work to protect and promote traditional tobacco use. We want to make sure that we remind you that traditional tobacco use is not addictive tobacco use. They're two very separate things. Tobacco addiction is a symptom of many root causes. Tribes are sovereign nations, and therefore state tobacco policy does not apply. And comprehensive tobacco control looks very different in tribal communities. There is a great new documentary available that you can find on the Clearway, Minnesota website, and I believe you can find it under the YouTube channel as well, and it's called Reclaiming Sacred Tobacco. If you want more information on this topic, I suggest that you go there. I am talking really fast because I am trying to make room for the other presenters, and up next is Dr. Begnaud. Thank you.
Thank you, Chris. Let's see here. I don't see the control buttons. Okay. My name is Abbie Begnaud. I'm a pulmonologist at the University of Minnesota, and I run our lung cancer screening program here. And I want to share with you today some updates on lung cancer screening, which is a relatively new screening program and a relatively new preventive care service for all individuals who have been smokers in the past to try to detect lung cancer early and save some lives. I am a paid consultant, but that is not related to anything we're doing here today. And we showed you some statistics, and I'm going to show you a few more about lung cancer. It's so scary, but there is hope. I think lung cancer screening and other new treatments on the horizon indicate there is hope, and so we should bother looking for it, and we should bother treating it. So today I'll help you figure out whom to screen, and we'll go over the eligibility criteria and a little bit about shared decision making. I intentionally have more slides here than I can reasonably cover thoroughly, but I want these to be resources available to all of the attendees to be able to review later if you need them in the future. We'll talk a little bit about how to screen and managing screening results. So some of the evidence for lung cancer screening is shown here. The purpose of this slide is to demonstrate that most people who present with lung cancer due to usual care, if they present due to symptoms, have presented once the cancer's already spread. And so on the left side you see presentation by stage, and only a small amount, the dark green number, are people who present with lung cancer when it is at a stage that has a good chance of cure. On the right side, the graph shows survival based on stage, and the best survival is for localized lung cancer. As it's spread regionally and more distantly, as you can see, the survival rates have historically been rather dismal. One thing that is starting to happen in Caucasian Americans, especially men, is that the mortality due to lung cancer is finally starting to come down. So that is reflected in the black line at the top, that overall lung cancer mortality rates seem to have hit the peak and are coming down. But the blue line that you see shows how American Indians and Alaska Natives are being affected by lung cancer mortality. And that number appears to still, that graph appears to still be on the incline, maybe plateauing, but we're definitely not on the downhill slope yet. And that's what we want to make happen. We want to start saving lives from lung cancer so that those numbers can go down too. Again, this is overall survival, so all comers with lung cancer surviving 5 years is 17%. And all these data are before lung cancer screening has been implemented, but this is why it's so important to try to detect lung cancer early and to improve chances for survival. So this is a study that was done several years ago demonstrating chest x-rays for lung cancer screening. For a long time we've been trying to figure out how to detect lung cancer early, knowing that that's when we have the best chance for cure. And this shows that chest x-rays alone are not adequate. So many people were doing chest x-rays in an attempt to try to help their patients, but chest x-rays are not adequate to find the small lung cancers that we want to find early and treat them. But there is hope. In addition to early detection through lung cancer screening, multiple new treatments for lung cancer have been approved. Some of the newer treatments are targeted to very specific types of lung cancer, and they're less toxic than traditionally when you think of chemotherapy. So with early detection through screening, we can shift the survival curve and shift the stage at presentation to save lives. So the National Lung Screening Trial was a large trial conducted in the United States, 53,000 patients over 2 years, and patients who were aged 55 to 75 years and had smoked more than 30 pack years, so that is defined as about a pack of cigarettes a day for 30 years. And who, if they had quit previously, had quit within 15 years. So could be current smokers, could be former smokers in the last 15 years. They were randomized to groups in the trial to either receive a low-dose CT or a chest X-ray annually. And they were followed for 6 years after the screening. The 3 screening exams were done over 2 years. They showed a reduction in lung cancer deaths and a reduction in all-cause mortality. So further analysis of the lung cancer screening trials demonstrate some of the screening metrics that we look at are similar to other breast cancers, or excuse me, other cancers that have screening programs in place. So breast and colon cancer, lung cancer screening with low-dose CT is equivalent to the other screening exams in terms of how efficient they are at detecting disease and saving lives. Cost is another issue when we talk about screening, and similarly, lung cancer screening with low-dose chest CT is in approximately the same range as mammography and colon cancer screening, which are currently accepted screening modalities. So as a basis of the trial that I just told you about, the United States Preventive Services Task Force did issue a recommendation for annual lung cancer screening with low-dose CT for individuals aged 55 to 80 years. People who had smoked about a pack a day for 30 years. It could be less than a pack a day, but more than 30 years. So half a pack a day for 60 years would be the equivalent of 60, or I'm sorry, half a pack a day for 60 years would be the equivalent of 30 pack years. If the person had quit smoking in the last 15 years, or more than 15 years, they should not be screened. And if someone has a health problem that substantially limits their life, or they're unable to undergo treatment for lung cancer, those people should probably not be screened as well. The recommendation from the United States Preventive Services Task Force is also really important, as that has ramifications for reimbursement through insurance, including Medicare. The arrows went away there, okay. Gosh. So this is one example of a lung cancer risk calculator. It's available at this website, shouldiScreen.com. It's freely available to anybody. You can put in information about an individual, how much they smoked, family history, age, and get an individualized risk for lung cancer. So what this risk says that this individual would have a 2.6% risk of developing lung cancer in the next 6 years. And this is one way to help people understand if screening would be valuable for them. The same website will also help you figure out if they meet eligibility criteria based on the USPSTF criteria, which was the same as the National Lung Screening Trial. We know that there are probably people who are at risk for lung cancer who don't fall into those very narrow windows of eligibility criteria, but right now those are the only ones that are reimbursed by major payers. However, this will also help you remember the screening criteria if you put in the patient's information. A few more decision aids that are available. Again, this is for reference in the future. All of these websites have resources for patients and providers to understand more about the risks and benefits of screening and help patients decide if screening is right for them. So shared decision making is the process that's recommended to occur between a healthcare provider and a patient before undergoing screening of any kind, but definitely lung cancer screening. In addition to determining eligibility based on smoking history, it's also a discussion about some of the risks and benefits. The risks of screening would be exposure to radiation, false positives. So many CT scans find a nodule or a finding that will need to be followed up, but ultimately is not lung cancer. And so that can bring along a lot of anxiety and additional testing. As we said, the decision aids can be used to help this. And this is also a really important time to talk to individuals about quitting smoking, which is really important even if they have a normal screening exam, and about coming back every year, because screening is not a one-time scan, but is an annual scan, just like a mammogram or other screening tests. So a little bit about the screening process. This will vary somewhat in different areas depending on what is available. Essentially, all patients should undergo shared decision-making beforehand, and in people who the provider and the patient decide that screening is right for them, they should undergo a low-dose CT screening exam. After the screening exam, you should expect to get a score, like a LungRad score, which is similar to the way that they read mammography for breast cancer, and that gives you an idea of the findings on the CT and the concern for malignancy, if any of them have that. Sometimes incidental findings are also noted. The CT scan will get a lot of other things, including the thyroid, including the heart, the liver. So there's a not insignificant about 7% incidental finding rate. So those are things that will also potentially need to be addressed. And whether or not individuals elect to undergo CT screening, it's really important to include smoking cessation assistance to all of those people. So here's a little picture of kind of what might happen for screening. So this would be a person in the office undergoing a shared decision-making visit, and if decided to do so, they would get an order for a screening CT. Patient would undergo a screening CT. It's a non-contrast CT. It's a very quick scan. In our institution, it takes just a few seconds. And if the scan is normal, they would get a what's called a LungRads 1 score, which means that nothing else to do besides annual follow-up, and so then they would return to an annual screening schedule. If something suspicious were found, in this case there's a large mass here, then usually people would be referred for specialty care, probably undergo a biopsy to diagnose the mass, and biopsy might happen through the chest wall, like this, would be done by a radiologist. Might happen through a bronchoscopy like this, which would be done by a pulmonologist or a surgeon perhaps. And then any patients, again, can have incidental findings. So some of the more common ones would be a nodule in the thyroid gland, an enlargement of the thoracic aorta, and for those findings, some additional testing may be indicated. So this is the LungRad scheme, and what you should note is on the left side the number. So as the number increases in size, there are associated with findings which are more suspicious for a malignancy. So a 1 or a 2 is something that would recommend annual screening in 12 months. Something in the 4 range would usually be short-term follow-up or perhaps a biopsy. So the incidental findings, as I mentioned, are fairly common. Usually these are going to be deferred back to the ordering provider. Some screening programs will manage all of the nodules for you, but most of the time they do not manage these additional findings. Some of the findings have consensus guidelines available to review. Some of them do not. It's always important to look for prior imaging if available. If a person has had a CT for some other reason in the past, that could be immensely helpful. And assessing symptoms and risk factors depending on what the individual finding is. So for example, some common findings which do have guidelines would be an aortic aneurysm or nodules on the liver, kidney, or thyroid. All of those have published guidelines. Coronary artery calcification is a very common finding which does not have consensus guidelines. Similarly for lymphadenopathy and interstitial lung abnormalities. I have a couple of slides following with some recommendations for all of these. I'm not going to go through those right now, but I hope you'll be able to refer to them later should you need to. So this is a summary of thyroid nodules, adrenal nodules, liver nodules, and kidney nodules. and some of the vascular findings, aortic enlargement and coronary artery calcification. When it comes to these patient risk and other risk factors are important to consider. Finally, I'm going to put a brief bit in here about payment guidelines. So the Indian Health Services, if that's the primary mode that patients would use, would have purchased and referred care, and this would fall under the level 2 care, which is preventive services. That includes cancer screening exams. For individuals with private pay insurance who meet the screening criteria, they should be covered without any copay. And for Medicare and Medicaid individuals, which may vary a little bit by state for Medicaid, again, the eligibility is the same. Medicare and Medicaid patients definitely have to have a face-to-face shared decision-making visit in order to be covered. Other individuals are not required to have that face-to-face visit. I think that's... Oh, okay. That's the same bit of information there. And a little bit more about some of the nuances of Medicare billing. There are several requirements which most screening programs should be able to help you meet in your area. Okay, Patrick.
Okay. Hello, my name is Patrick Roberts, and I'm a health policy fellow with the National Native American AIDS Prevention Center. And I work as a health policy fellow in collaboration with the Caring Ambassadors program, and together we kind of address healthcare disparities within the Native American population. And some of those efforts really kind of include building relationships on the community-based level, outreach, advocacy, and then also empowering our community members and tribal leaders to talk about health issues that they don't normally talk about. And some of that includes, as you know, lung cancer, but other issues with regard to hepatitis C infection and HIV infection. So that's a little bit about me. Some of the advocacy efforts that I'm having trouble moving forward. Here. Okay, so some of the community partnerships that we've developed over the course of the year, one, as I've explained, is the Caring Ambassadors program, and then also our new partner is the American Indian Cancer Foundation, and then also the University of Minnesota. I'm based in Denver, Colorado, and some of our advocacy partnerships are the Denver Indian Health and Family Services, Denver Indian Family Resource Center, and then also we get to the West Coast and work with the Native American Healthcare Center, and then also various Department of Public Health organizations, both in San Francisco and in Albuquerque. So let's talk about smoking and then address some of the needs for cessation and quitting smoking. A study in Minnesota was conducted. It was basically a survey of Native populations, and is considered one of the largest surveys of Native populations. Showed that 59% of Native Americans smoke, which is a large number, and really kind of speaks to the need to address this as a public health issue, and then also work and engage our community members to talk about the need for efforts to stop smoking, but also address lung cancer within our communities. Okay. So this is a slide that actually Chris noted on earlier, so I'm not going to really go much into that, but it just shows that you know, the tobacco industry has really targeted our community and really have focused on our behavior patterns and disparities that really kind of make us addicted to nicotine. So I just won't go too much into that slide. But I do want to talk about traditional uses of tobacco, which Chris also engaged in. She spoke to why tobacco within our community is used. And traditionally, tobacco is used in spirit and celebration of our and we use it for prayer and for the well-being of our family. We use it to pray for our family. But recently, the tobacco industry has really targeted our community due to our trauma, and really has focused on addiction within our communities, which is evident within the use of our cigarettes smoking within our community. So when we continue to smoke at such a high level, 58% of us are smokers, we lose our sense of spiritual connection to tobacco, and that's something that the tobacco industry really kind of wants to focus on. And when we continue to smoke, that sense of spirit is gone. So those offerings, those signs of respect, the prayer, the use of medicine is lost. So we really need to kind of address why we need to quit smoking. Trying to move to the next slide, I apologize. And some of those reasons I pointed out are the spiritual connections, the loss of our native ways. But we also need to look at this as a health component, and it's important to talk about why we need to quit. We all know that smoking isn't good, but every 2.5 minutes, someone is told that they have lung cancer. So if you do the math and you really calculate this out, this is about 1,440 people per hour and roughly 17,000 people per day who are told that that they have developed some sort of lung cancer. So we need to really kind of address this as a public health issue and talk about the behavior patterns. If we don't, these numbers will continue to rise. So smoking cessation, 70% of smokers want to quit smoking. They've in fact implied that they want to quit smoking, but 41% have tried and they don't always succeed. They continue to smoke, and there's a number of reasons why, but the number one reason is the big elephant in the room, and that's nicotine. In a cigarette, there's about 7,000 harmful ingredients in a cigarette itself, one of which is tobacco, and we all know that, one of which is nicotine. And we all know that nicotine is highly addictive. It stimulates the brain. And the way it works, really, when you think about it, it's very clever. Nicotine kind of stimulates the brain and causes a pleasurable experience. So when you smoke a cigarette, your brain is stimulated. It's called the acetylcholine receptor, which releases dopamine and causes instant gratification within the body or within the brain itself. And it causes people to rely on cigarettes and to continue to smoke, which is, we all know that, this dopamine effect stimulates and gratifies you, and it causes people to continue to seek out that dopamine release. So thus, you continue to smoke. So because nicotine attaches to certain receptors, when you quit, there are certain physical and mental reactions that happen within the body itself. When you try to quit, anxiety and irritability set in, agitation sets in, you have problems sleeping, it's difficult to sleep, and you have an increased appetite, and your urge to continue to smoke is heightened. So once this happens, really we need to kind of look at and address practical ways to quit smoking. We need to develop tools to be able to utilize so that we can actually stop smoking. Some of the most practical approaches are nicotine replacement therapy, the use of a transdermal patch, which kind of releases the nicotine in the body over the course of time through the skin and blood. Short-acting nicotine replacements, which are gum, nicotine gum, inhalers, lozenges, and nasal sprays. And it's important to think about when you utilize these tools, you can utilize them as a singular, or you can actually use them in combination to be able to stop smoking and stop the craving for nicotine. This next slide really kind of suggests, I mean, Chris kind of pointed out that you know, there is a need for education and resources. You know, basically 2/3 of those individuals who were surveyed in Minnesota, the 3,000 cohorts, 2/3 of those individuals don't necessarily know how to engage practical methods to stop smoking. They don't know how to utilize educational resources as tools to be able to do that. So this slide really kind of represents exactly what needs to happen, the options that can be utilized to be able to stop smoking. Also, the American Indian Cancer Foundation has a Facebook page that actually that actually can be engaged to stop smoking. So it's important that maybe if you're thinking about smoking to join that, because it's a really great way to use community-based efforts to be able to stop that smoking and address your need for for stopping. Also, the Caring Ambassadors Program, American Indian Cancer Foundation, and then the NAPSI is developing culturally sensitive brochures to be able to actually utilize ways that you can quit. So that's will be on the resource page, or you can download those handouts and actually get the website addresses on the handouts. There are notable benefits to quitting smoking, to quit smoking, and it's never too late. This slide kind of highlights a lot of benefits to the smoking, but I just want to point out 3. Number 1, when you quit within 20 minutes, your blood pressure and heart rate decrease. And number 5, within a year of quitting, the risk for coronary disease is cut in half, which is pretty amazing. And then number 8, after 15 years of quitting, your risk of coronary disease is that of a non-smoker, which is a huge benefit to quitting. So, you know, you reduce certain risk of coronary disease, lung cancer, the need to continue to monitor your health. But one thing you need to understand is when you're quitting, you need to talk to a medical professional and seek out help, and then seek out resources that I've just discussed, which are on our website pages to be able to be able to quit. And if you fail, to try again. It's not always an easy effort, but if you utilize these practical methods, it can be done. So at this point, I'm just going to hand over to Cindy, who is with the Caring Ambassadors Program, and let her finish up our slide presentations.
Good morning, everyone. My name is Cindy Langhorne. I'm the Lung Cancer Program Director for the Caring Ambassadors Program. We provide patient education and support to lung cancer patients and their loved ones. I know we are really tight on time as far as Q&A. We do have many resources at our website, caringambassadors.org. For some reason, my slides are not showing up. But we have Lung Cancer Choices 3rd edition, Caregiver Choices, which is a companion piece specifically written for lung cancer patients' caregivers. And then we have the following resources available at caringambassadors.org. So please check out our website. I know we only have about 4 minutes left, so I'll turn it back to you folks for Q&A.
All right, can everybody hear me now? Cindy, can you hear me okay?
I can.
All right, excellent. Okay, I had to jump over to my cell phone because for some reason it wasn't working on my regular phone.
No problem.
Anyway, hopefully everybody can hear me okay now. With that, what we'll do is we'll go ahead and start taking some questions. Already there's a bunch of questions in here saying that it doesn't work, the sound doesn't work, et cetera, from early on here. So I think now we're beyond that. Edie Rodewald had a question. What was the name of the website to find the video Reclaiming Sacred Tobacco? If find somebody who has an answer for that.
Hello, this is Chris. It is available at clearwayminnesota.org. Again, that's clearwayminnesota.org.
And I'm just going to wait around, see if we have any other questions here. We got about 1 minute left. We do want to give a plug here for our website. We're going to archive the webinar on our website at keepitsacred.org. We also do want to remind everybody that there will be a survey going out tomorrow to complete to fill out for your CEU credits. Let's see here. We're still waiting on another question. It looks like we've got about 1 minute left for a question, if anybody has a question. And I don't see any questions coming up. Let's see here. What is the meaning behind calling it Indian country and not native country?
I've actually heard it addressed both ways. I think the norm for me and what I've heard within our community, I'm Native, and most people that I work with call it Indian country, but I think it's, it can be cross-referenced as both.
Okay. All right, with that, we've got about 10 seconds left, so we're going to go ahead and wrap everything up. Thank you very much to everybody who was able to attend. And again, visit keepitsacred.org. Thank you very much, and have yourself a good day.
Go ahead.
Thank you.
Thank you.